Welcome everyone to our webinar. We are going to talk today about everything you always wanted to know about EDS, Ehlers-Danlos Syndromes, and HSD, hypermobile spectrum disorder. The agenda for today is we're going to start with an introduction of the speaker and the moderators. Then we're going to give you some tips before starting. Then we're going to get your answers solved about everything you always wanted to know about EDS and HSD. Afterwards, we're going to check the questions from the audience. We're going to recap with a final take, and we're going to say goodbye to you after that. So here's a brief introduction of the speaker and the moderators. The expert speaker of today is Professor Franziska Malfait. She's head of clinic, Center for Medical Genetics, University of Ghent. She's associate professor affiliated with the Center for Medical Genetics at Ghent University Hospital and at the Department for Biomolecular Medicine at Ghent University in Belgium. She is Chief Scientific Officer of the Ehlers-Danlos Society and head of the International Consortium. She's also member of the EDS disease group of the Unraveling. And then as moderators, Teresa and I are going to be your moderators today. I'm Eva. I'm an ePAG advocate in RECONNECT, European Patient Advocate. I'm the Vice President of UNCED, the Spanish patient organization for Ehlers-Danlos Syndromes and hypermobile spectrum disorder. And as mentioned, I'm advocating for EDS and HSD within RECONNECT. And also, I'm also an ePAG advocate in Basken for vascular EDS. Teresa is my partner in crime today. So Teresa, please.
Good afternoon, everyone. My name is Teresa. I'm also president of the Bindweefsel.be, the Flemish, one of the Flemish patient organization for connective tissue disorders, which is also EDS. I'm also the ePAG advocate here in RECONNECT, and I have several different European positions with EMA, Eurordis, and also a patient expert with the EDS Society or International Consortium, and have other positions as well here and there. Next slide. Before we start, I'm going to explain to you the scope of the webinar and housekeeping rules. Next slide. The scope of the webinar is to solve patients' and carers' questions about Ehlers-Danlos syndromes and hypermobility spectrum disorder. Questions were previously collected through a survey from the year-end RECONNECT EDS disease group. Questions will be answered live by experts, and in addition, the chat is open for your questions. The questions will be presented grouped by categories. Due to the amount of questions we received, a second webinar will be organized. The questions will not be answered that are not answered during the webinar will be answered and published in the year-end RECONNECT EDS disease group website. Next one. Now some housekeeping rules. You can write your comments and questions on the chat. Language of the webinar is in English. However, we have, as you've heard, translated live captions into your mother language. This can be activated. This webinar will be recorded and published in the year-end RECONNECT website and YouTube channel. Disclaimer, this webinar is meant for informative purposes and cannot be taken as a medical consultation. So how do you activate the translated captions? As you see in your Zoom bar here underneath, you click on Show Captions. You open Caption Settings. You activate Translation. The speaking language is set on English. And you choose the caption language and select your native language. We will try to speak slowly as possible so that you will be able to read the subtitles in your own language.
So we are getting straight to the point of this webinar. We are going to try to solve everything you always wanted to know about EDS and HSD, and Professor Francisca Malfait is going to answer the questions. So as mentioned previously, the categories that are going to be dealt with today are diagnosis, clinical diagnosis, genetic diagnosis, and also biopsy. The second one is management, third one is research, and the last but not least, the rarer types. So we are going to start with the first category, clinical diagnosis. This is a sample of the questions we have received from you. The first question that relates to clinical diagnosis. Why does the Byton criteria only consider hyperlaxity in those joints? Why not in TMG, for example, which is so typical in us? Another participant in the survey asked, what is the difference between HDS and HSD? Another question we received, how can an early diagnosis of HDS be made in children when there is an absence of genetic findings to date? So I will leave the floor to Francisca.
Okay, thank you very much, Eva and Charissa, and thank you all for asking your questions and for attending this webinar. And so I will do my best to answer today some of these questions. There was not much time for preparation, but I think some of the broader questions, like we said, with regard to diagnosis and management and so on, can be tackled today. First, I'm going to try to share my screen. And could you let me know if you can see these slides?
Yes, we can see them.
Yes. Okay. So first of all, I'm going to scroll a bit through some of these slides. The first question was regarding the Byton score, and I'm gonna try, for those who are not familiar, I think I have a slide that shows, maybe not. So the Byton score is indeed a score, a 9-point score that investigates how flexible, how mobile you are. And so it's a score where you look at hyperextension of your little finger on both sides, of your thumb on both sides, your elbows, your knees, and then also it looks at the mobility in the hip joints. And so it looks at whether you can touch the floor with your both hands without bending your knees. So in general, this is a score that looks at a limited range of joints. And so the question is indeed, why does it only look at those joints and not at other joints? Because people with generalized hypermobility, of course, have joint hypermobility in many joints. So actually, the Byton score is a score that has been developed so that it can easily be investigated, for instance, during a clinical workup and during a consultation. It's quite quick, it's quite easy. And so it has actually been validated to be representative for generalized joint hypermobility when you have a score that, depending on your age, is higher than 4, 5, or 6. So here you can see the Byton score. So if you have a score that is, you have joint hypermobility, if you have a score higher than 6, if you are pre-puberty, higher than 5, if you are between puberty up until the age of 50, and before over than 4 if you're over age 50. However, of course, there are a lot of factors that can influence the mobility in those joints. For instance, if you have had surgery in one of those joints, this could influence the Beighton score. Or if you had an injury, or on the other hand, if you do a lot of sports, like for instance, ballet, to give an example, it could make you more flexible. So there are a lot of environmental factors throughout your life that could make the Beighton score either more positive or more negative. So indeed, that's why it is also stated, for instance, in the publication on the diagnostics of hypermobile EDS and also other types of EDS. If the Beighton score is negative, then if you have the impression that a person is hypermobile, it is definitely worthwhile and even necessary to look at other joints, including, for instance, the temporal mandibular joints and a lot of other joints to look for generalized joint hypermobility. There is also, for instance, a 5-point questionnaire where we can look at historical joint hypermobility. So if an older person is not hypermobile anymore, according to the Beighton score, you can also assess historical joint hypermobility with this questionnaire, 5-point questionnaire. So just in summary, the Beighton score is something that has been validated to assess generalized joint hypermobility, that is easy to use during a clinical consultation, but it's definitely not the best tool ever to assess generalized joint hypermobility. And if it's negative, you should assess other joints. Second question was, what is the difference? And that's a question that we heard or that we read a lot. What is the difference between hypermobile EDS and then hypermobility spectrum disorders? And that's actually a very good question. And it's a question that we also still struggle with a lot. But just maybe from a historical perspective to illustrate where do these terms come from. So first of all, hypermobility type of Ehlers-Danlos syndrome is a term that was developed, let's say, more by the geneticists. So in the genetics world, it was recognized that there was this group of people who had this combination of joint hypermobility and then the skin hyperextensibility and atrophic scarring, etc., all these skin features that we see in EDS. And then we started, a long time ago, we started to find genetic defects. So we found genetic defects, for instance, in type 5 collagen EDS, and we called those patients classical EDS. But then there was this group of patients who had clinical manifestations that were a bit like classical EDS, although the skin manifestations were less severe, and we did not find genetic defects. So that was when this group of patients was called hypermobile EDS. And then in 1997, during the development of the Villefranche classification that was used for a long time, clinical criteria were developed to define hypermobile EDS. And those said you have to have a positive Beighton score and you have to have some involvement of the skin, but less extreme than what we see, for instance, in classical EDS. And then you had some minor criteria being this joint dislocations, pain, and a positive family history. And then in that publication already, it was said or recognized that there are a large number of patients with generalized joint hypermobility. And that's what the publication then said. It is important to distinguish these individuals from those affected with hypermobility type of EDS. There is a considerable debate as to the causal relationship, if any, between a hypermobile person on the one hand and a person with hypermobility type of EDS. So it's since a long time, it's been a debate whether it's one condition or different conditions. But with these diagnostic criteria, it was thought that the hypermobility type, that these criteria will permit to have clear distinction between other types of EDS and also other hypermobile disorders. So that was when the Villefranche criteria were developed. In the meantime, in parallel, in rheumatological practices, it was also recognized, of course, that there were this large number of people with joint hypermobility. And then when they had a lot of problems, they were called joint hypermobility syndrome. And it was also recognized that these people had some skin manifestations and some other manifestations of connective tissue fragility. And then there were clinical criteria developed for joint hypermobility syndrome. And when you put those next to the Villefranche criteria for hypermobile EDS, they were overlapping, but not quite the same. So that was very confusing. And in the end, by many rheumatologists, geneticists, and other specialists, those two conditions were considered to be one and the same. And the terms were used interchangeably, both in clinical settings and research settings. That's why it's so confusing. So then in 2017, an international committee developed new criteria also for hypermobile EDS and also for other types of EDS, but also for hypermobile EDS. And I'm just gonna switch to this slide here. This shows the different criteria for hypermobile EDS. And so they are now much stricter than the Villefranche criteria. And so I'm not gonna go into too much detail because of time, but so you have three criteria. Criterion 1 is you have to have generalized joint hypermobility according to a positive Beighton score. You have to have two or three other features being, you have to have some signs of connective tissue fragility other than the joint hypermobility, and that can include, for instance, also some skin manifestations of EDS, but also others such as mitral valve prolapse, and for instance, also herniations. You can have a positive family history showing that this is a genetic or at least a heritable condition. And you can also have, or you should also have complications of the musculoskeletal joint hypermobility being dislocations and or pain. And then also very important, we have to be sure that other causes of joint hypermobility are excluded. So we have to be sure that it's not another type of EDS or another heritable connective tissue disorder, such as, for instance, Marfan syndrome, or another rheumatological disorder that is associated with hypermobility. So those are the criteria for hypermobile EDS. They are very strict and they are very clear, let's say. If you are hypermobile and you have associated problems of dislocations, pain, and even mild connective tissue fragility, such as some bruising or some fragile skin, but you do not fulfill the criteria for HEDS, nor any criteria for another condition or any other non-genetic condition, then we call that a hypermobility spectrum disorder. So there are no very strict criteria for HSD. It's more of an exclusion diagnosis. So that's the difference with regards to classification between HEDS and HSD. That said, we do see often, even for instance, within one family, that one person fulfills HEDS criteria and then another not, and then is diagnosed with HSD. Or sometimes even during the life of one person, people can, it can change, and then sometimes they do fulfill the criteria and then it changes. And actually, as long as we do not know the exact cause, whether it's genetic or non-genetic causes for HEDS or HSD, we are not 100% sure that these are two different conditions, or maybe one spectrum, one group, a group of, that is a spectrum of one and the same condition. And then the third question, and I do not have a slide for that, but the third question was what about children? How do we diagnose children when there is not a genetic marker? Also a very good question. And that's not easy because children are more flexible than adults. That's also why there is a so the Beighton criteria in children, in pubertal children, should be the Beighton should be at least 6 out of 9. But it's not because your child has a Beighton score of 6 or 7 or 8 that it has EDS. So you also have to have other signs of connective tissue fragility to make a diagnosis of EDS. So in children, it's very difficult to make a diagnosis of HEDS. In fact, in Ghent, here in our center, we refrain from doing that. When we have a child that is hypermobile, according to the Beighton score, that has problems with it, first of all, we make sure that it's not another type of EDS. So if necessary, we do a genetic test. And then we follow the children until they are older. We give them advice with regards to management, to physiotherapy, etc. But we don't give a diagnosis until they have reached puberty, until we have seen the evolution, because often you see that hypermobile children, when they grow older, when they go through puberty, the hypermobility becomes less outspoken, they don't have any problems anymore, and we don't want to label them with a disease when we are not sure about that. So that's how we tackle that in Ghent. So we do a follow-up and we do management, but we wait with a definite diagnosis until they are older. So maybe I will stop sharing my screen so we can go to the next questions.
Thank you, Franziska. So we are moving on to the genetic diagnosis. Some of the questions we have received regarding this topic are how to get to genetic testing, or is the same type of EDS inherited from your parents, or does it vary from generation to generation? Will my daughter have the same symptoms as me? Another participant asked us, many of us have variants of uncertain significance with clinical signs of EDS, but no Beighton criteria. Should we be diagnosed with hypermobile EDS, or should we be left without a diagnosis? And the last question is, can I have classical EDS and be hypermobile to the highest degree without that meaning that I have hypermobile EDS?
Okay. So maybe if you could maybe just leave the questions there,
Sure.
because I will otherwise forget. So first of all, how to get to genetic testing? Well, I guess that depends a bit on where exactly, in which country you live and how easy access is to genetic testing. So here in Belgium, usually you have to come through the medical genetics department. So we get referrals from our colleagues, specialists, cardiologists, rheumatologists, physiotherapists, etc. When they have a suspicion of a rare type of EDS, and then I mean a type that is genetically defined. So for hypermobile EDS, of course, we don't have a genetic test because the genetic defect is unknown. But if we want to be sure that we are not missing another type of EDS, you should try to get to a medical genetics center and have a geneticist examine you and then decide whether it is indeed indicated to order a genetic test, so that all the genes that are currently known to be associated with EDS can be tested. The next question is a very good question that we often get from people, and where there is often a lot of misunderstanding. So is the same type of EDS inherited from your parents? So yes, within one family, you will never switch from one type of EDS to another. So if, for instance, your father is affected by a vascular type of EDS, then that vascular type of EDS is caused by a genetic defect in the gene that codes for a specific protein that is type 3 collagen. So you have a type 3 collagen defect. Then if the father transmits that defect to the child, it will always be the same type 3 collagen defect. So it will always be the same type of EDS. It will always be a vascular EDS. It will not suddenly change to a classical EDS or to a hypermobility type of EDS, for instance. So yes, you do always see the same type of EDS within one inherited from one generation to the next. But also very important to know is that, and that's the second part of this question, will my daughter have the same symptoms as me? No, even within one type of EDS and even within one family, so people affected by the exact same genetic defect in one family, there can be quite a broad variability, so changes or a different presentation of the disease. So we can see, for instance, if you would have a family with classical EDS, so that is caused by defects in type 5 collagen. Type 5 collagen is a very important protein in your body. So when you have a defect, it leads to classical EDS. The hallmarks of classical EDS are generalized joint hypermobility, like we see in hypermobile EDS, but also a very stretchy skin. So people can really stretch their skin, often very wide, and then abnormal wound healing with the formation of very thin and very large scars. But within one family, sometimes in one person, you only see the joint hypermobility and only very mild implication of the skin, while then in the child, you can see that that child has a very fragile skin and large scars, but has very mild joint hypermobility. So that's what we call variability within the same condition. So it's not because you have the same defect and the same type of EDS as your mother or as your daughter that your symptoms will be exactly the same. So that's very tricky. Then the next question, many of us have variants of uncertain significance with clinical signs of EDS, but no Beighton criteria. So a variant of uncertain significance or a variant of unknown significance, a VUS, that is so when we do, as geneticists, when we do genetic testing of your genes and we find an abnormality in your genetic material in one of the EDS associated genes, sometimes we just don't know what it does, what that variant does. We don't know whether it's disease causing or whether it's just a benign variant that actually does not lead to disease. And our genetic material is full of variants that are not associated with disease. So we have to be careful in interpretation of variants that we find in your genetic material. And so indeed, the more genetic analysis we do, the more variants of uncertain significance we find. If we find a variant of uncertain significance in a person who has clinical signs of Ehlers-Danlos syndrome, even when they don't have a positive Beighton score, we have to look very carefully. First, we have to try to make sense of the variant of uncertain significance. And I'm just gonna quickly, maybe can I share my screen again? I'm gonna go back to my presentation. So here, yeah. So a variant of unknown significance here that's recapitulated. It's a variant form of a gene that has been identified through genetic testing, but whose significance to the function or to the health of our body is not known. This is as opposed to a mutation, that's a change in our genetic material, in our DNA sequence, that alters the function of the protein, so that is disease-causing. So when we are certain that it is disease-causing, we call it a mutation. When we are not certain, we call it a variant of unknown significance. And so, yeah, I'm gonna skip this. But first of all, when we find a variant of unknown significance in a person who has some signs of EDS, we try to make sense of that variant. And so sometimes, but not always, we can do additional studies to investigate whether that variant actually has an impact on the function of the protein that is encoded by the gene in which we have found the variant. One very important thing that we do is family study. That means that we will see whether we can track that variant in your family members. So for instance, if you have signs of EDS and genetic test has revealed that you have a variant of unknown significance in gene X, then what we will do is we will ask blood from your father and from your mother and maybe from your sisters and brothers, check whether we find that same variant in some of your family members. And then also, and that's a very important step, check whether the person who also carries that variant also shows signs of EDS. If yes, then that could be an argument in favor of that variant being actually a disease-causing mutation. If not, then it could show us that this is just a benign variant. So there are also sometimes, depending on the gene, other studies that we can do. We can do a skin biopsy and then actually investigate the protein on that skin biopsy. So, but those are steps that we as geneticists can take to try to reclassify, to make sense of that variant of unknown significance. Could I have the questions back, please? Thanks. So, and then should we be diagnosed with hypermobile EDS or should we be left without a diagnosis? That really all depends on the variant of unknown significance that has been found. It depends on which gene where we find that variant, whether the EDS signs are compatible with the gene that we find the variant in. So we definitely not automatically diagnose a person with EDS signs with a variant of unknown significance as hypermobile EDS. We also not always leave those persons without a diagnosis. It really, really all depends on the clinical manifestations. And that's why a thorough clinical examination by a person who is really familiar with EDS is very important to try to make sense of that variant of unknown significance. And then the last question is, can I have classical EDS and be hypermobile to the highest degree without that meaning that I have HEDS? Yes, definitely. So also very important questions because there's always a lot of confusion. So between the different types of EDS, there is a lot of overlap. So most patients with any type of EDS are hypermobile. Most patients with any type of EDS have easy bruising. It does not mean because you have hypermobility that you have hypermobile EDS, and then on top of that, another type of EDS. So people with classical EDS often have hypermobility to the highest degree. They have classical EDS, then they don't have on top of that hypermobile EDS. We also get that a lot with easy bruising. People often think because I have easy bruising, I have vascular EDS on top of my other EDS diagnosis. That is not true. We do see easy bruising in almost all patients with any type of EDS, also often in people with hypermobile EDS. So that does not mean that you, on top of that, have vascular EDS. I
Thank
hope
you very
it's
much,
clear.
Francisca. So we move on to the next, to the next category, which is biopsy. This is a quite popular question amongst the patient community.
Yeah, I think it's an important question. I'm gonna keep my answer brief in view of time, but skin biopsy is absolutely not helpful for the diagnosis of hypermobile EDS. So often it is being done to do a microscopic evaluation of the collagen structures in your skin. And sometimes there are laboratories who make a diagnosis of hypermobile EDS based on collagen abnormalities that they see on a skin biopsy, but that's actually not correct. It's not accurate. Collagen abnormalities can be seen in other types of EDS, can be seen in other connective tissue diseases, can be seen in other non-EDS conditions or non-hereditary diseases, and can even be seen in an older normal skin, let's say. So a skin biopsy does not allow to make a diagnosis of hypermobile EDS.
Thank you very much. So we're moving on to the next category. Teresa?
The next category is management. The questions that we received on this, the first question is, what is the big difference for a patient if this disease can be diagnosed at a young age instead of later in life? The second question we received is, does it get worse with age? Or the third, which doctor carries out the follow-up? Another person asked, are there any collagen-enhancing drugs and preventive treatments to stop the skin becoming thinner and thinner, so dangerous in old age? And the last question in this category is, having EDS or HSD treated differently in terms of disability or incapacity?
Okay, so I think it's actually important to be diagnosed at a young age, if that is possible, because there are indeed we don't, of course, for all the EDS types and HSD, we don't have really a therapy that a curative therapy, unfortunately. But there are a lot of preventive measures that you can take, and it really depends, of course, on the type of EDS. But with regards to joint hypermobility, for instance, we do see, if you recognize that this is actually there and a problem at a young age, physiotherapy can be really very helpful. Exercises that strengthen your muscle proprioceptive, that enhance your proprioception, all of those things are really helpful, and we do see in our daily practice that this could actually delay the development of pain problems and other problems, musculoskeletal problems. Also knowing that you have this disease can help you in make decisions about which sports you will take on or which sports you will not do, or also which profession you will do. So really it will make you, it will give you cues into which lifestyle decisions that you can make, and that really can make a difference later in life. Especially then also with regards, for instance, to vascular EDS, where there is a risk for ruptures or dissections of your arteries, or also other internal organs. Knowing that you are affected at a younger age instead of later in life, also allows you to take preventative measures that can delay or or make sure that you don't have these type of complications. So avoidance of surgery, for instance, when it's not really necessary to have a surgical event is all very important. Does it get worse with age? That really depends from one person to the other, from one EDS type to the other. I would say in general, we do see that as people age, they tend to have more problems, especially related to musculoskeletal problems and pain. But really, not one EDS person is the same as the other, so it's very difficult to make a broad statement about this. And then also, in addition to that, I should say that there are actually to date no really good long-term follow-up studies that have followed larger cohorts of EDS patients throughout life. So of course we have our daily experience, but not much of scientific data to strengthen that. Which doctor carries out the follow-up? Yeah, that's a very important and not easy question. I should say that it also depends on the type of EDS. So for instance, here in Belgium, for the rarer types, and I mean then again the types where we find a genetic defect, we try at the genetics department to follow the patients and see them like once a year and make sure that they have all their investigations. For the hypermobile type of EDS and HSD, that's a much larger group. That is something that is not possible actually to manage from within a genetics department. I think there a physiotherapist, of course, is very important, or a rheumatologist. That really depends a bit from one European country to another, whether it's a rheumatologist or a physiotherapist that follows the joint hypermobility and the problems that are related to that. I think a general practitioner is also has a very important role, but there is a lot to do from our side, I would say, to educate those clinicians so that they feel comfortable following up patients with HSD and HEDS. Collagen enhancing drugs, unfortunately, there are not very good collagen enhancing drugs. First of all, it really doesn't help to take collagen in any form or shape. It's not by ingesting collagen or putting collagen on your skin that you will strengthen the defective collagen. It unfortunately will not do anything. The only thing that could be somewhat helpful, especially with regards to bruising, that's vitamin C, because that's a vitamin that is important in the synthesis of your collagen in your body. But unfortunately, with regards to the skin becoming thinner and thinner, there is not so much you can do. Avoid corticosteroids if possible, because that's also something that will make your skin thinner. And then at younger age, protect your skin with pads, etc., so that you have as few scars as possible. And then, is having EDS or HSD treated differently in terms of disability or incapacity? I think it is definitely treated differently in reality, but it should not be treated differently. I mean, there are people with HSD who are much more disabled than patients with EDS because of their joint hypermobility. And so we should actually look at how people function and what they can do rather than the diagnosis. So I think they should not be treated differently in terms of disability and incapacity. In reality, we know that, yeah, it's not always the case.
Thank you. The next category are questions about research. The first question that we received is what is being done to discover the genetic origin of the hypermobile Ehlers-Danlos type? And the last question is research being carried out to ensure that future generations will not be so badly off or that it can be checked immediately after birth whether the child has EDS.
Okay, so for the first question, I can say that there is indeed a lot going on with regards to trying to unravel the genetic origins of hypermobile EDS. So I think many of you, or maybe not, but have heard of the EDS Society, which is an international organization that is involved in all aspects of EDS. And so they have, together with the International EDS Consortium, a few years ago started a study which is called the HEDGE study, trying to unravel the genetic origins of hypermobile EDS. And so they have gathered blood samples from 1,000 persons throughout the world, many of them in the United States, with the diagnosis of either hypermobile EDS or HSD, and on genetic sequencing, whole genome. So they looked at the whole genetic sequence of all those individuals and are now trying to find patterns within this genetic material that could tell us something about the causes of the hypermobility in EDS. However, while we are doing that, it's becoming more and more clear, and I think we already knew that, but that the causes of hypermobile EDS and of HSD will be very complex and probably not purely genetic in origin. And so now also other studies are starting to take place because there is this international organization now that that works together and collaborates to try to do this, looking at maybe immunological causes, viral causes, metabolic causes, etc., and other environmental causes. So, but yes, there is so the good news is that there is a lot being done to try to do this, but it's all research takes time and a lot of money, and it is a very complex puzzle. So let's hope that within the next decade we do find some answers. And then is research being carried out to ensure that future generations will not be so badly off, or that it can be checked immediately after birth whether a child has EDS? So yes, definitely also there. A lot is ongoing also for the rarer types of EDS. So if in a family a genetic defect is known, then you can already check now whether the child has EDS at birth, or even before birth, or even before implantation. For those families where we don't know the genetic defect yet, whether hypermobile EDS or other types of EDS, with the advances in the technology for genetic sequencing, I think we will discover more genes for EDS or more defects for EDS in the future, so that we can check other people whether they have EDS, and hopefully as early as possible in life. And then I think the field is also more and more moving towards trying to find curative therapies, but that's definitely in a research stage, but thinking about how we can actually modify our genetic material so that the disease either becomes less severe or actually can be cured. This is still far future, but at least people are starting to think how we can actually do that.
Okay, the last section that we have is the rarer types. We have two questions. In my family, the mutation is ARG31-2EU in COL1A1. Has this mutation already been accepted as EDS? Are there more known cases of patients with this mutation? And then the last final question, I want to know how many patients are diagnosed with the subtype spondylitis EDS in the world and in Spain.
Okay, so for the first question, so here we are going to a very rare and very specific group of patients who indeed have a very specific genetic defect in the gene that codes for type 1 collagen. And so that mutation had been discovered a while ago, first in one family, then in a second family, and then after that in a few other families. The question, has this already been accepted as EDS, is probably because normally mutations in that gene cause another condition that is called osteogenesis imperfecta. But this very particular mutation indeed gives rise to a clinical image that is characterized by what we actually see in classical EDS, joint hypermobility in association with a very stretchable skin, atrophic scarring. But we do see that people who have this very specific mutation are at risk of also having vascular problems, a bit like we see in vascular EDS. I can actually say that this mutation is accepted as a form as EDS, yes, because the presentation is very clearly an EDS presentation. The only thing is that for now, we don't have a very good name for it. So we don't want to call it classical EDS, because classical EDS is actually caused by defects in another gene. And usually people with classical EDS are not so much at risk or less of having these vascular complications. On the other hand, we do not want to call it vascular EDS because people with vascular EDS have a much more outspoken risk for vascular complications, and their skin and joint manifestations are different. So it's somewhere in between those two conditions. And so actually we are having by 2026, so currently we are working towards a new classification for EDS. So we had a 2017 classification. We are now revising that with our international consortium, and hopefully we will be able to, that needs a lot of preparation, we will be able to finalize that by 2026. And one of the points that we will discuss during that revision is how shall we implement this type within the new classification? How shall we call it? And then, yeah. So, and at this point, I think there are about 20 families and about 35 people worldwide that we know of that have this particular mutation. And then about the spondylodysplastic type of EDS, here the answer that I can give you is less specific. First of all, there are actually 3 types of spondylodysplastic EDS caused by defects in 3 different genes. And they all have a bit of their own characteristics. So they differ a little bit in their clinical manifestations, but they all come under the broader denominator of spondylodysplastic EDS. That's a type of EDS where you do see the typical skin and joint manifestations of EDS, but on top of that, people also have a sort of skeletal dysplasia, so bone disease. In total, the number of spondylodysplastic EDS patients that have been identified worldwide is also probably for the 3 types together around maybe 70 at most. I don't know how many in Spain. That's a level of specificity that I cannot give. And there were also a few other questions I remember from the survey about spondylodysplastic EDS. But the thing is, with regards to the clinical manifestations, because some of these diseases are so rare, we don't know the full spectrum, let's say, of clinical manifestations that can be associated with this type, because every time we find a new patient with this particular disease, we see new clinical manifestations because of the variability that I already mentioned within all the EDS types. So it's very important, I should say, that clinicians and geneticists and people who see people with all these rarer types of EDS, that we also keep reporting them to each other and in medical literature, so that we learn the extent and the broad extent of clinical manifestations and the natural history also of these diseases.
Okay, we received some questions from the audience. I think we have time for 2 questions to answer, because you have they relate to the questions that you asked previously. The other questions that were asked, we will definitely answer these questions and we will publish them on our website within the next few weeks. So keep your eye on our website and we will publish them. The questions that we have is, can I have EDS type 5, 11, and 14?
EDS type 5, 11, and 14. Let's see, I'm just gonna go to my presentation and try to see if I can show. Just 1 minute. Because I don't know by heart even which is 5, 11, and here. So 5 is hypermobile, I guess. Not sure. What was the other?
11, musculose.
Skeletal,
MC
and
EDS.
14 ABP. So no, you never have different types of EDS all together. So a type of EDS is, except for hypermobile EDS, based on the gene in which we find a genetic defect. So if you have, for instance, a genetic defect in the genes that code for type 5 collagen, and that's here in the classical EDS, COL5A1, COL5A2, you see this. If you have a genetic defect in those genes, you have a classical type of EDS, even if you have joint hypermobility, even if you have some muscular weakness that could maybe fit within the musculocontractural EDS, even if you have bruising, even that could fit within vascular EDS, even if you have an arterial rupture. It's the genetic defect that defines the type of EDS. It's not the different manifestations. So you have one type of EDS. You don't have 2, you don't have 3, you don't have all of them together.
Okay, then the next question is, what's your opinion about the genes of folate or homocysteine and the relation with hypermobile syndrome, MTHFR and MMP2, and LOX gene, MIA3 gen, and more?
Oof,
if you
a
if you
lot.
want to read it, you can read it by the questions.
Can I see them in
By the Q&A.
Sure. There, Q&A. Okay. Opinion, the genes, folate, homocysteine, and yeah. So at this point, there is no, no proven association between the genes for homocysteine and hypermobility syndrome. I know that there has been some suggestions about this, that this could be related, but we would need good studies, association studies that would actually show that there is an association. And so far, that's not the case. LOX gene MIA3 also for those, so there is no, actually, except for the tenascin X, where there have been in the past a few reports of abnormalities in tenascin X associated with hypermobility. No other gene has formally been linked with hypermobility syndromes. So not any of those that are listed in the questions. So there is also, maybe if I can pick up the next question, because my eye falls on it. So is there any no connection between vascular EDS and other collagen or cartilage autoimmune diseases? Should I genetically test it after an artery injury? So to the first part of that question, there is no known connection so far between vascular EDS and autoimmune diseases. Should you get genetically tested if there is not a clear explanation for the artery rupture, and depending on your age and where the rupture was, that's really definitely an indication to get genetic testing for vascular EDS. Yes. So, okay, I'm gonna not take over. I think we're near the end of our hour, probably.
Could you please stop sharing, Franziska?
Oh, yes, definitely.
And we switch. So we're going to wrap up. We wanted to finish this webinar with this known quote, at least within the patient community, from Professor Ronnie Graham, EDS specialist, rheumatologist, researcher, and pioneer. And no other condition in the history of modern medicine has been neglected in such a way as Ehlers-Danlos Syndrome has. We think it is still relevant today, and we still must keep on raising awareness for EDS and HSD, as we are trying to do with this webinar, included in this International Awareness Month, May. So actually, we would like to thank you, first of all, Franziska, for this wonderful opportunity and for this amazing webinar. Thanks to ER and Reconet also for giving us this space, as said, within this International Awareness Month. Thanks to everyone that submitted the questions. Actually, it has been a quite successful survey, and we have more than enough questions to keep on offering more webinars like this. And of course, thank you to everyone that joined today. We will meet again in our next Everything You Always Wanted to Know About EDS and HSD webinar. It will be organized soon. So as Teresa mentioned, keep an eye on our social media website in order to be informed. So thank you, everyone, and have a nice afternoon.
Thank you.
Thank you.
Bye.